Welcome, this is Colleen Doak, Associate Professor at St. Ambrose University, and this PowerPoint presentation is on epidemiological study designs. So, some basic terms that you'll need to know when we talk about study designs. One is the concept of a cohort. What is a cohort? A cohort is a group of people who share some common characteristic. So you can think of this in terms of an entering class for an academic program. So all of you who started your MPH program, your cohort could be the group of people that you started in the term that you started, or your cohort could be more broadly everybody who started within a 1 or 2 year time frame. So how broadly you define that cohort depends on the aims of your research. So it's not something that's fixed in stone. A cohort could be, for example, the baby boomers or Generation X or millennials. That could be considered to be a cohort. Now, in doing your research, you have to decide, am I going to have a closed cohort if people enter the study? Am I allowing new people to come into the study after I've started my study? That would be considered an open cohort. Or am I going to just start with a certain group of people? If I lose them, I lose them, but I'll follow that same group of people up for as long as I can or for the duration of the whole study. So the closed versus open cohort is a difference between whether or not you have new people in or out, or whether people are allowed to flow in and out of the study. Now, research designs, we have a number of research designs, but they can be categorized roughly in terms of the time frame. Are they longitudinal in study design? Are they testing over time? Are you measuring your exposure and waiting for the follow-up and the disease outcome to occur or to be prevented? Or are they cross-sectional? Are you going in at one moment of time and collecting all the information together? Now, that doesn't mean the exact same day, but over a several month period, are you collecting information, asking people for their exposure and their outcome in the same interview process? The third point is something we call a retrospective study or historical study. So that's where you might go in and instead of doing everything based on the time frame of now, you may ask people about their past exposure, or you may actually go into the records and identify their past exposures. So that's where we start to talk about a retrospective or a historical research study design. And often they'll talk about a historical cohort. What they mean then is you have a group of people, you're asking them questions, and you're going back in time to collect information about their earlier exposures. So what is an ecological study? So the first study design is something called an ecological study, and this is something that's not well covered in the book, so I'm going to give it a little more attention here. And this is a pretty common study design, especially for research questions that are just being explored, where there's some large level data, like country level data, and you want to identify what characteristics at the country level or policy level influence the outcome, like disease. So this is something you can imagine already in terms of COVID-19. So that's where you would take different groups and you'll compare all the analysis at the group level. So how is it that different countries compare in terms of COVID-19 outcomes in relation to gross national product, in relation to healthcare access, in terms of government policies, things like that. So the exposure would be something that's a group level exposure, like per capita gross national product, country policy, per capita dietary intake, if you're looking at something like dietary fat intake and breast cancer, for example. And then the outcome is a disease rate that would be recorded and available at the group level. So a rate of disease per 100,000 people in the population. So this is something that's commonly reported in the case of COVID-19. There are a number of concerns related to an ecological study because we don't actually know if the individuals who are exposed in what we're measuring are actually the individuals who get the outcome that we're measuring, because everything is kept at the group level. In spite of this, there are a number of strengths of an ecological study, and that is that some of the group level data is actually more stable and easier to measure than individual level exposure. So if you're talking about mean per capita intake or group level data in terms of policies, that's information that is best taken at the group level. Also, data is easier to access and widely available at the group level sometimes, so it depends on what your research question is. So if that data is available, you should use it. Why not? As your first level of exploration, you can use the data that's already available without imposing questions or an additional study process on people. Disease rates from a large population are relatively stable. They have small random errors because of the large sample size. So that's an advantage of an ecological study. And another thing is because it allows you to explore information with data that's available, it can help in sort of disentangling what might be happening. So it's what we call hypothesis generating. It helps us to sort of explore ideas and come up with hypotheses. But there are also, of course, a number of limitations. I've already referred to the fact that individual and group level data may not line up. So that is the fact that the reliance on the population rather than individual level information can mislead us. Another concern is that the data may not exist. So maybe you have a particular research question, but you can't do an ecological study because they don't have group level data on it. So if you wanted to look at different policies in relation to COVID-19, you would have to have that information on the policies, implementation, and adherence as much as possible. Another issue is that the results cannot be independently reproduced because it's a process of depending on existing data. And because of that reliance on population rather than individual level information, there's something we call a spurious relationship, and it has its own terminology when it comes to ecological studies. We even call it the ecological fallacy. It's really important that you know about the ecological fallacy because this is the idea that sometimes the results at the group level are opposite to the results when you actually have individual level information. So as an example, at the group level, imagine you found that per capita dietary intake is associated with breast cancer risk. But maybe if you look at it more in depth, you might find that at the individual level, it may be that a higher fat diet is being consumed by the men in the population, and it happens maybe not even related to breast cancer risk at all. So maybe the population that is most at risk for breast cancer, of course men can also get breast cancer, but maybe the population that is most at risk for that outcome is not the population that is actually consuming or experiencing that exposure. So the spurious relationship that results is what we call the ecological fallacy, which comes from using data at the group level and inferring an individual level relationship when in fact that relationship does not exist. And we won't know whether or not the relationship is true or not without having individual level data. So that is why an ecological study is always followed up with information and analysis at the individual level. One of the first study designs that was developed in epidemiology was in the midst of a cholera epidemic. John Snow identified relationships between water source and cholera. What did he actually do? Well, what he actually did is he developed a study that's called now a case control study, where he looked at people who had cholera and he compared them to people who did not have cholera in relation to their water exposure. So I'm going to describe a case control study using this example, and then I'm going to show you on the next slide the example using our current pandemic, COVID-19. So here is a case control study. It is where you take disease cases and you identify them and you compare them to a non-disease control population with respect to exposure. And what you're actually measuring, you're trying to understand, is this disease related to that exposure. And in this process, you're actually doing it the backwards way around, where you're identifying the people with the disease first, and you're looking to see what their exposures are. And so this is sort of a quick and dirty approach to efficiently exploring, is there an association between this disease outcome and an exposure? So the association is measured using what we call an odds ratio. That is an estimate of risk that is actually what we call an exposure odds ratio. It's looking at how likely is it that the cases are exposed. And by finding out an association between whether the cases are more likely to be exposed, we're actually identifying whether or not that exposure is associated with that outcome, so that we interpret it very often in a way that's similar to a risk ratio, where we say that that exposure is associated with being more likely to have the disease. So it's a current cross-sectional analysis, but it allows us to get an estimation of a concept of risk. So here's our 2x2 table, and the formula for the odds ratio is, in the cases, what are the odds that they are exposed versus not exposed, compared to the non-cases, being exposed versus non-exposed. And so we use this formulation of a 2x2 table with the quadrants of the table marked as A, B, C, and D. And this is a very common notation that we use in epidemiology. And for the odds ratio, we very often change the formula around using principles of math so that we can cross-multiply and use the formula of A times D divided by B times C. So I'm giving both of these formulas. You can use either one, and I will show you on the next slide how that second formula can be really helpful in identifying the odds ratio without actually having to do much complicated math. So here is the same study design approach, case control study, and our cases are going to be COVID-19 cases, and we're going to compare them to people who do not have COVID-19. And specifically, this is going to be a hypothetical example of whether access to masks, I'll say PPE, but more specifically, whether or not individual access to protective equipment, such as masks, are associated with COVID-19 and nursing staff. So let's say you have an analysis, and you could look at nurses who have positive tests for COVID-19 and compare them to nurses who do not have positive test results for COVID-19. And you ask those nurses who had COVID-19, did you have access to protective equipment? Particularly, did you have access to protective masks? And let's say 50 out of 80 of your COVID-19 cases did not have access to masks. So that would mean their odds of not having access to PPEs would be 50 divided by 30. That's your first odds, your odds of not having access to the equipment. Then in your non-cases, the ones who are nurses but do not have COVID-19, that's a reference group, we ask them, did you have access to PPE equipment, specifically masks? And maybe out of 310 of this control group, 10 said that they did not have access, but the rest of the 300 said they did have access. So they have a very much lower rate of answering that they did not have access to PPEs. So how do we put this into a formula that relates to a risk concept? Well, what we do is we do that cross multiplication. If you look at that 50 times 300 divided by 10 times 300, well, that's a 5-to-1 ratio. So I don't even have to pull out my calculator here, because in this case, it just happened that that 300 shows up in the numerator and the denominator. I can cancel that out. 50 to 10 is a 5-to-1 ratio. So they are 5 times more likely to say they do not have access to PPEs. Now, we often interpret this the other way around, which is also true. Those who are nurses who did not have access to PPEs were more likely to have developed COVID-19 in this analysis. So here's a case control study where we can say what is the risk relationship or the odds ratio of having access to or not having access to PPEs and developing COVID-19 for nursing staff. So what are the strengths of a case control study? First of all, you should know that it's less time consuming. You can go in at the same moment, you identify the cases, you identify the exposure, and you can take those same measurements in a control group of people who don't have the disease condition. So in one moment, you can get the information efficiently in terms of time, and that also is efficient in terms of money. In particular, it's an efficient method for a rare disease. If you were to start the study and look for whether or not access to PPEs were related to COVID-19, you would have to wait a certain amount of time to allow for the disease to develop. Now, in addition to having to wait for that extra time, which is inefficient, there are also ethical concerns. You can't study a group of nurses who don't have access to PPEs if and when you know that PPEs are essential to preventing COVID-19, or even if you think that it is. So in the early days of COVID-19, it was really important to get a handle on to what extent are PPEs important in the disease spread, and this approach allowed for identifying the risk related to COVID-19 in response to PPE exposure. Now, I'm not giving an actual real example, but this is how it would look if you were to really quantify the risk related to PPE exposure. It was enough to identify that nurses were developing the virus and for people to understand that the PPEs were not enough for the level of protection needed. So a case control study is really efficient for a rare disease because of the time it takes for a rare disease to develop and the number of people you need to start with when very few people get the disease. So in a longitudinal study, that would take a large sample size. In a case control study, you can start with the diseased group, so you don't have to wait. You don't have to have a very large exposure group in order to get enough people. It's also efficient when you combine the rare disease with a fairly prevalent exposure. PPEs and nurses should be a relatively prevalent exposure. Also, you can explore associations that are related to increased risk. So you wouldn't be able to do this study in even a longitudinal way because it wouldn't be ethical. So we know now that PPEs are associated with the disease, the virus, so you wouldn't be able to follow over time nurses whether or not they have access. But after the fact, you do want to measure to what extent did not having PPEs contribute to their risk of getting the virus. And that's information that we can use now, and we can also use as we look ahead to prevention methods, not just for this current pandemic, but any future pandemics that we encounter. So there are a number of limitations of a case control study, and these are really important. First of all, a case control study requires a very large population, both in terms of cases and controls, if the exposure is very rare in the population. So if you're looking at a population where almost none of the nurses have access to PPEs, a case control study would not make much sense because it would require so many cases and so many controls to get any kind of analysis that you could work with. You need the numbers. You need at least to have 5 in each of the cells. Another issue here is, remember, we identified the cases and controls, and we identified their exposure based on a question that we asked them. Did you have access to PPEs, in particular masks? So recall bias is likely, and recall bias is the idea that people who have the disease will remember differently than people who did not have diagnosis with the disease. So retrospective assessment, because of recall bias, introduces a greater chance of error than if you assess exposure before there's any disease condition that occurs. The other issue comes up, and this is not in the example that I've given, but it might be in a dietary analysis. Let's say you have an outcome like cancer, and you ask people about their current dietary intakes. Now, obviously, if you have a condition like cancer, you're likely to change your dietary intake. So any current assessment with the assumption that a current assessment is indicative of ongoing exposure will not really work if you have a disease outcome where people may change their exposure. They may actually change their behaviors. So it doesn't accurately reflect their past exposure, their exposure in the time frame that you were really interested in. Now I'm going to move on to the next type of study design. We talked about a case control study, which is a type of a cross-sectional study. We're going to next talk about a longitudinal cohort study. And a longitudinal study, as I've said earlier, is a research design studied over time. And a cohort is a group of people with a common experience. So in this type of study, the exposure is assessed at the beginning of the study, and the cohort is followed over time. New cases of the disease are then identified, and risk of the disease in the exposed group is compared to the risk in the unexposed. So you already have to know from the onset, how long am I going to follow people? At what point do I stop following people and do my analysis comparing how many people got the disease in the exposed compared to the unexposed groups? Okay, so in summation, there are a number of strengths of a longitudinal study. And the first is that exposure is assessed first. So it's not assessed after the diagnosis, it's assessed before the diagnosis. So there's really no chance of recall bias related to a diagnosis because the measurement is taken before the diagnosis ever occurred or the disease ever developed. Second, if all study subjects are then tested for the disease, that would also eliminate any bias that would be related to diagnosis. So in a longitudinal cohort study, there could be bias related to diagnosis if you're measuring an exposure that is thought to be related to the disease outcome. Doctors may be more likely to diagnose lung cancer, for example, in somebody who is a habitual smoker. And so if you're following an exposure that is well understood or believed to be related to the outcome already, it's probable that those people will be more likely to be tested for the disease. If you consistently test everyone for the disease at the end of the study, then that eliminates any bias related to diagnosis or access to health care. Now, a longitudinal study design also has an advantage in that it would be possible to have repeated assessments of the exposure. So let's say, for example, with the nurses, I'm not just interested in their ever exposure to having access to PPEs, but I recognize that PPE masks in particular have not been steadily available over time, so they might have access at some times and not at others. A longitudinal study design would be able to disentangle those differences in the exposure and to identify time frames where people had more exposure or less exposure. Finally, with a longitudinal cohort design, because you're not actually implementing an intervention, you can observe association that may be related to increased risk. You would not be able to obviously give that exposure, but you can monitor and observe it. Now, the limitations of a longitudinal cohort study are also important to note. First is, if it's a rare disease, it takes a lot of people that you have to follow over time before you get enough people who develop that disease. So in this respect, COVID-19 is actually a rare disease. A cohort study is going to take a long time to get any information that would be useful in a statistical analysis. Secondly, it is costly depending on how long it takes and how many people. So if you have a large sample size or a long time frame, so let's say it takes 30 years to develop the disease, that's going to cost a lot too. There's a high subject burden because it means that they can't just answer all the questions in one go or over a couple of weeks. You're going to keep coming back to them over a longer time frame, and they will have to answer the questions at least at the beginning and at the end of the process. So because of that high subject burden, there is often a high loss to follow-up. So that is going to be a source of bias in your results. And finally, if you don't have testing as part of your study, there will be diagnosis bias in the exposed group, particularly if physicians are more likely to diagnose them based on the fact that they're exposed. Another concern is access to healthcare. People with greater access to healthcare are more likely to get diagnosis. Now, a final study design, there are others, I'm giving you the main study designs, is a double-blind randomized controlled study. So study subjects in this type of study design are randomly allocated to an intervention or a control. And that control you can talk about in terms of a placebo. So if it's a pill, you would get the pill or you would get the placebo, or you might, instead of a placebo, get what we call standard care. So ethically, you're always required to provide standard care. If there is no standard care, then you would provide a placebo. Ideally, the study subject and those conducting the study would both be blinded to the assignment, so the preparation of providing the pills, placebos, would be done behind the scenes and would be done based on number allocation so that the researcher who's interacting with the study subject would not know their assignment. What are the strengths of the randomized controlled type of study? All of the potentially distorting variables, we're going to talk about those as confounders, are randomly distributed in a large study sample. So in other words, this takes away any potential sources of bias related to socioeconomic status or other variables that might distort your results. The intervention approach also allows researchers to assign a greater difference in the exposure that might naturally occur. So you might say, well, we see in research a difference between people who have a high fruit and vegetable intake versus those who don't, but if you did an intervention where you really gave a certain level of exposure, like say, for example, a vitamin, beta carotene, for example, you could give an exposure level that maybe people wouldn't naturally consume. Now, this could be a negative, particularly if it causes a negative consequence, but usually this is done when there's a belief that people in the population are not getting the intake that they need to meet their needs in terms of health. So what are the limitations of a randomized control study? Obviously, it is one of our gold standards that we use because it provides experimental evidence, it shows temporality, the exposure occurs before the outcome, but it is not always appropriate to randomize the control group. So if you're giving a necessary intervention, like for example, if you're giving an intervention like PPEs, you can't give PPE masks to one group and not to another. That would be unethical. You can only explore associations that are protective against the disease. So if you think that a relationship might increase the risk, you have to turn it around in a way that you're exploring something that is beneficial. So let's say, for example, you think that not eating fruits and vegetables will increase the risks. You need an intervention that will give people fruits and vegetables. Studies are limited to outcomes that can reasonably change within the time frame of the trial. So that is something that you have to think about. If a disease takes decades to occur, like, for example, cancer, a randomized controlled study would simply take too long to be feasible.